Um, Thank you. Good afternoon, everyone. Thank you. Sorry for the delay. We will start our session, the congenital session of the 2021 annual meeting of the SCTS. It is a case presentation session, and I welcome with us our three speakers from Liverpool, Alderhay, Mr. Rafael Guerrero, from Birmingham, Mr. Phil Bota, and from Newcastle, Mr. Mohammed Nassar. We will start with the presentations. As we are a little bit late, I will put the floor for Mr. Guerrero to start his case presentation. Thank you, Rafael.
Thank you. Thank you, Sama. Yeah, we came with this idea with Mohammed. We're trying to organize this meeting in view that we don't have, post-meeting coffee shop or post-meeting pub to have a beer and discuss about cases, because that was the place that we normally discuss cases. We said, all right, let's try to do a discussion of cases that we think, not to show off these cases, and which we think that will be useful for the whole group to see what will they do. So mine is going to take 2 or 3 minutes, and then it's open for a few minutes for discussion, especially hopefully from the floor to ask questions or mainly to give their opinion. So please, can we run this quick video? Hi, good afternoon, everyone. So today we are going to do in our next part of the meeting is about decision making, about when to operate and when not to operate. So this is one of 3 presentations. It's going to be very brief because the whole idea is to discuss among all ourselves about how we should do in these cases. So I'm going to start with one case from Alderhay Children's Hospital, and it's all about single ventricle decision making. And my colleague will follow with the other 2 presentations. Briefly, it's a baby with 1 day old, 3.4 kilograms, antenatal diagnosis of hypoplastic left heart syndrome, unbalanced ABSD, started on prostaglandins and transferred to Alderhay Children's Hospitals on the 24 hours of the stable conditions. These are the echocardiograms that I'm going to show to you, and obviously each one can have a good view of the echoes, and we can try to repeat them later. I hope that the view is okay in the small screen, but we'll try. Here there is more views of the echocardiogram. And we did a CT angiogram. Again, I try to put it as big as we can so that we can have a good look at the aortic arch, descending aorta, and the ascending aorta. That's another view of the CT angiogram done. I'm showing the coronary artery as well. And a 3D reconstruction. For all of us is trying to decide what should we do with this baby. There's several options. These are some of the options that we have put. So should we do a normal procedure? Should we go a hybrid procedure for hypoplastic left heart syndrome, or we go for compassionate care? So I hope that you enjoy the case, and then we can start. So we can start discussing soon.
Thank you, Rafael. It's a nice, typical nightmare case. So Rafael, I will start just the discussion, if you don't mind. Is it a routine for you to do a CT on these patients?
No. So hypoplastic left heart, which are kind of a standard, with a good size, the anatomy is clear, and you have, you can actually visualize the ascending aorta, you can bisolate the arch. We just do, as probably most centers, just echocardiogram and then decide for an operation one or the other. So in this case, obviously we went for a CT scan because the ascending aorta was probably invisible and was very subjective to the cardiologist. One says 1 millimeter, the other one say 1.2, the other one say 2, etc. So we say, well, we need another one to have a good look.
Let's see. And was there anterograde flow through the aorta at all?
No, it's mitral atresia, aortic atresia. So there was no anterograde flow. All the flow is retrograde through the duct all the way.
While I'm looking at the audience, whether there are any questions, Phil and Mohammed, feel free to get into the discussion.
Hi, Rafa.
Hiya.
Can you hear me?
Yep, very well.
So I guess you would have told us if there's significant other comorbidity. I presume the genetics are normal and brain scan and abdominal scan is normal?
Yes, so in this particular case, which was unusual, there was no significant brain abnormality or genetic abnormalities on the renal ultrasound and the kidney ultrasound. And the weight wasn't bad at all for a hypoplastic for us. The majority that we get are under, around 2.5 kilos. So no major comorbidities. The only thing was that. And I'm really sorry that the echocardiograms are difficult to see, because I thought that for everybody to have their own view. The interlateral septum was slightly narrow, so there was a bit of interlateral septum problem as well. But
communication, is that right? Was the communication restrictive?
Yeah, slightly restrictive. Not completely closed, but slightly restrictive ASD. Mitral atresia, aortic atresia, and as you can see, essentially diminutive.
You said unbalanced AVSD, but you're saying mitral atresia. Is it?
That's the antenatal diagnosis. At the end, there was no left side.
Well. And the valve, to me, on the echo pictures that I could see, the valve looked pretty competent. Is that right? It's a reasonably good AV valve?
Yeah, the AV valve was only mild AV valve regurg, so there was no significant right AV valve regurgitation. And the left side was small, and the antenatal diagnosis of unbalanced AVSD probably was postnatal was not like that. And the pulmonary venous drainage was normal, and the aortic arch, as you can see, was not a bad size, and there was obviously a huge PDA.
And was born in good condition, Rafael?
Born in good conditions in the hospital, yeah. From a precious baby, as you can interpret it that.
Yeah. Just to, before we ask you, what did you do? In such patients, what's your strategy normally? Without telling us what you've done to this patient, what would be the pathway for a patient who's hypoplast? I would take this cohort of patients, mitral atresia, aortic atresia. What is the pathway for those normally, Raphael?
We kind of ignore the aortic atresia, mitral atresia, if you want to call it, because the big chunk of the patients that we get in the Northwest, for some reason, they have a combination of both things. So then we cannot rule them out at all. So they go into a group that if they need to be operated, if the other factors are okay. So no comorbidities, the tricuspid valve is adequate, with mild at the most moderate AV valve recurge, and you have a good ascending aorta, we just carry on, and even with intact septum, or sometimes we have that. So the rationale to carry on just for a standard Norwood will do that. If we need 2 or 3 cases in the last year, actually we went for hybrid, that mainly was because was massive sepsis from a case which we couldn't go into a Norwood, so we hybrid and then Norwood 3 or 4 weeks later. And the other case was very similar to this one. We have 3 in a row with a very, very small ascending aorta and multiple comorbidities. And in that case, we decided to hybrid him, which is doing fine. And then we'll see with an intact septum, or nearly intact septum. We decided to hybrid, and then it's gone home, but then we'll decide what to do in the future to either comprehensive second stage or no.
There is a question on from Karen. You answered part of it, but there's a question about the coronary fistulas. Did the patient have any coronary fistulas?
Not that I'm aware. So it's not that it was picked up in the echo on the CT scan.
And you've answered that pulmonary veins were okay, and we saw that the AV valve was good.
Yeah.
And in terms of the ascending aorta, I presume that you operated on this patient. What was the size of it?
So we probably have, So the answer is no, we did not operate in the patient. So the ascending aorta was probably on measurement less than 1 millimeter, not even 2. And so because we have a similar case, probably a month before that, 2 similar cases. One about the measurement on echo say, it's about 2 millimeters or so. But, and I will tell you about the story about that case. But in this case, we decided, so is that with retrograde, so there's no antegrade flow. So the only source of flow to this ascending aorta is retrograde, which has been going on since the baby was in utero, and it hasn't grown. So that looks like, like atretic. And the ascending aorta was smaller than the coronary arteries. So we went through the surgical exercise, right? So if we do a Norwood, how feasible it will be for us to enlarge all the way to the ostium of the coronaries without distorting that either in a double barrel or in the way that we do it, which is similar to Birmingham. And probably with that, I'm not sure if that was going to work. Plan B is if we do a hybrid, is this going to grow or not? And the hybrid, the only thing that you're changing is still retrograde flow. So the only thing that you're changing is just limiting the amount of blood going to the lungs. So, and the septostomy. So we decided that probably that's, with our experience in the past, looked like that's not going to work. And then we contemplate, compassionate care or not. And we, check with the parents as, we suggest the parents to have a second opinion or third opinion. I think there was one national, one international. And the opinion was that, no, just compassionate care. And so we did not operate in that case. Sorry for bringing the answer so soon.
I didn't want to push you to that, but I suspected that there was something quite important. Did you contemplate a solution that someone has actually presented? So I think it was from Barcelona, a surgeon from the previous generation who used to, in such cases, to actually leave the aorta as it is and do direct connection to the arch without doing anything to the aorta and leave it for a few weeks or maybe months and go back. I mean, this aorta is tiny, but did you think about that?
Yeah, what we thought is, because here is this aorta, the question was, is this aorta have potential for growing or not? Because that's the key of the whole thing. And mainly because essentially it's like a very long left main stem, isn't it? Because because it's, the only thing it's doing is just giving you coronary flow. So if this is going to, sorry, it's raining outside. So if this is going to grow or not. And I don't know if we are right or wrong, but we thought with a previous experience that probably this is not going to grow anymore because it's already getting integrated. So, and the solution for that, we just do a hybrid, and that will allow, again, flow going to there and buy time, and that will give you the answer if this is going to grow or not. But then we decide that, well, one of the few options, but with a previous case that we have, which I was kind of caught because similar case, a smaller case, intact septum, and probably maybe it's a little bit bigger than that, but I didn't know until I opened the case. The aorta was diminutive. So, and that's the point when I measure the coronary probes, that the ones that I say 1 or 2, essentially they are 0.3 because they are French. So we measure that, and that was 1 millimeter in that probe. So I did the whole Norwood and everything, and it came off. And then probably 24 hours later, the ventricular function went off, started slowly to bend off, arrest, and everything like that. And we put it on ECMO. And we did all the angios. There was no obstruction anywhere. But the only thing is that the LV function was gone, probably secondary to coronary perfusion, as like chronic coronary. That's my theory of hypoperfusion. And I took it back to explore, see if I can make that DKS bigger, if I can, repair the AV valve, everything like that, but it didn't work. So with that experience, probably one case in which a little bit bigger aorta, things didn't work. And I think at coronary perfusion or chronic coronary hypoperfusion, that's why we explore the possibility of doing nothing, which was very hard because it's very difficult for us, probably the same of all of us, to reject a case or not to do something. It's just so difficult to do that. And that's what we did.
Mohammed, did you want to add something?
I want to say something. I just want to remind you that maybe before the Norwood, the hypoblasts were, treated with transplant. So I'm not saying that this can go for transplant from the start, which could be, but it's time-wise, it might not be an option, but maybe hybrid and less for transplant was an option in this child.
I think that if we were in Boston in the States, or if we were in Emory or whatever, we probably will do that because it is very clear that the pathway of hypoplastic in America and other places is either Norwood or even in Germany in Gießen. So it's Norwood or you can transplantation. But knowing the UK situation of transplantation for that, maybe I think that is a really good point, and maybe we should have discussed with Newcastle or GOS if we hybrid this case, what are the chances of going and having a transplantation? I think that's a really good point, but we didn't do that.
Raphael, I tell you my own experience actually in here. One of the patients I had similar with a very small ascending aorta, probably a tiny bit bigger than what you're describing, the aorta, but it was essentially a minuscule ascending aorta, very long as you showed us. And actually we operated on that patient, and we the septum was restrictive, very similar. So I had actually at the same time to do septectomy when I did the hybrid. He had an anomalous venous return. I had also mixed anomalous venous return, so I had to deal with that. And we hybrided the patient at the same time. he went on and he actually grew his aorta, but it wasn't massive. Even when I went exactly the same. I did a rapid Norwood within a few weeks. And when I went back, the aorta was still small. But by then, what happened to the child, he was in a poor condition to start with. He was much better in general. And that allowed probably for his survival. The operation was absolutely challenging. You are anastomosing the LAD essentially to the damus, so it's tiny, but it is very difficult to make those decisions. I completely agree with you, and I think compassionate care should be part of this, and we have this. Luckily, you don't get these patients, too many of them. So, but it has to be part of it. And I accept your thought, Mohammed, about actually discussing with a transplant center if we feel that actually that is the right thing for the child in general, if the general condition allows it. Phil, anything you wanted to add?
I didn't know that I'm just presenting on one case, so I've actually cheated. I've got 2 cases and some presentations, so I think I'm going to suggest some of the things that I think we think about here. But I don't feel like neonatal or infant transplant is really an option for us. It's so rare that we get a donor, and the time frame, if you look at how long patients wait, even in the US, on a hybrid or even on more complex types of support, these are very long wait periods. So I think, Rafa, your approach is reasonable. You said the parents, it was a precious pregnancy. That is often what forces us into trying. And, the whole evidence, and in the end, the AV valve is good. So it comes down to that ascending aorta and getting good blood supply. And the literature says, occasionally it says it's not a problem, no matter how small it is. And on other occasions it says, well, no, it is a problem. And I think if you see an aorta like that, it would be extremely surprising if it's never a problem, right? But you can only try, and you anastomose and do a damus. And I think there's no, in my opinion, there's no benefit from a hybrid. Personally, I think we would probably do a Norwood if we're going to offer something, and try and get right down, as you did, right down into the root, basically. And do the anastomosis to that to try and open that out as much as you can, but it is challenging for sure.
Yeah, I think thank you for your comment, because we are reaching the point in some cases in which should we do something or not, and it's so hard to make that decision, because we love to operate and we love to do challenging cases, but then we need to think about how we want this to go. And I remember overnight we reviewed the literature again, because I said, well, let me see if anything, looking at outcomes of small ascending aorta, the main things like AV valve rigors, intact septum, small ascending aorta. And the truth is that there is no papers about this, 1 or 2 papers that is all involved in a big piece, in the whole cohort of patients. So it's very difficult to dissect and decide or say, what happened with the less than 2 millimeters. And I remember probably Bill, when he started the program in Birmingham, they were, 2-3 millimeters were the cut at the time. But obviously, more and more we are pushing to doing those cases who were, in theory, inoperable. We just carry on and doing it. And I don't know if in this case was the right decision or not. And that's what we said, like, let's see what everybody else thinks. Anyways, thank you for all the comments. I hope that you enjoyed it.
Thank you. Thanks, Rafael. Shall we move to the next presentation? Phil, do you want to start, please?
Good afternoon, and thank you for the opportunity to speak at this meeting on the topic of single ventricle, when to treat and when not to treat. We'll all probably accept that a single ventricle palliation can be considered of high risk of failure, but perhaps even more importantly, of high risk for poor long-term outcome, including poor quality of life for a number of reasons. Impairment of ventricular function or abnormal valve function are perhaps some of the more common anatomical features that make us consider alternatives to stage single ventricle palliation. The dependence of the successful Fontan circulation on a well-developed pulmonary arterial tree make the spectrum of pulmonary arterial development through the range of hypoplasia to discontinuous pulmonary arteries and multifocal pulmonary blood supply a particular concern. Similarly, pulmonary venous obstruction due to intrinsic venous pathway abnormality or restrictive intraatrial communication are a particular worry. Of course, significant neurological, pulmonary, immunological, gastrointestinal or genetic comorbidity have been repeatedly demonstrated to be associated with similarly poor outcomes. In settings where neonatal and infant transplantation are a realistic alternative, some of these subgroups have been identified as having better outcomes if directed initially towards transplantation, and increasingly complex strategies have been adopted to allow successful bridge to transplant. At the same time, this has led to continued improvement in the results of single ventricle palliation for the remaining patients that undergo single ventricle palliation. In the United Kingdom, this is not an alternative available to clinicians and parents, and we are often left in a situation where parents are unwilling to accept palliative care as the only alternative management strategy when there is any chance of survival and quality of life with single ventricle palliation. Our own uncertainties and absence of data for rare combinations of lesions make this perhaps even more difficult. A clear message is seen in the literature: stop creating bad Fontans. But the suggested changes in management are focused mainly on earlier intervention for significant valve lesions, and some uncertainties about the efficacy of this strategy remain. Particularly right and common atrioventricular valves have been shown to be a less durable substrate for repair, and diverting from the single ventricle pathway to transplantation is again the suggested management strategy in this scenario. Of course, repeated reoperations at a young age, risk sensitization, and ineligibility for transplantation, and there are unlikely to ever be enough donors in our practice to help all of our most complex single ventricle patients. I have two brief cases with unusual anatomical lesions and some common themes I would like to present, these having caused considerable debate among the team in Birmingham over the last few years. I will conclude with a brief summary of the literature on the much more common problem of AV valve regurgitation that causes frequent discussion and concern. The first patient had an antenatal diagnosis of unbalanced atrioventricular septal defect with right ventricular predominance on the hypoplastic left heart spectrum and was thought to have a diminutive aorta. The parents were counseled regarding the likelihood of requiring single ventricle palliation and the possibility of valvular problems adding complexity in the setting of a common atrioventricular valve. They nevertheless chose to proceed with the pregnancy, and a baby boy was delivered by cesarean section at 39 weeks gestation, weighing 3.8 kilograms and in good condition. Proston was commenced, and the postnatal echocardiograms demonstrate an unusual combination of unbalanced atrioventricular septal defect with pulmonary dominant common arterial trunk and interrupted aortic arch type B. The truncal valve was trifoliate with trivial regurgitation, and the common AV valve similarly good with mild regurgitation. The child was intubated for cardiac CT and subsequently failed extubation due to rising lactate and overcirculation. The imaging was reviewed in our MDT, and these images are representative. The diagnosis of common arterial trunk with type B interruption was confirmed, and from the posterior view of the CT reconstruction on the left, you can see that the pulmonary arteries have crossed origins. Although absolute branch PA size was adequate and peripheral arborization was good, there was of course some concerns that the unusual PA anatomy may impair growth and ultimate suitability for Fontan completion. We discussed staged biventricular repair, but the overall consensus was that the left ventricular cavity was far from adequate at 50 mils per meter squared, and the left AV valve component was similarly small with poor substrate for angled septation. We had not long lost a patient after a particularly difficult course with single ventricle palliation in the setting of common arterial trunk. And a keen registrar interrogated our database for all patients with the combination of truncus and single ventricle, and the results were sobering. Over 30 years, we have seen 5 patients with single ventricle truncus at Birmingham, 4 with unbalanced AVSD, and 1 with tricuspid atresia. 2 were treated along a palliative care pathway, one which had trisomy 21 and another with severe truncal valve regurgitation. 3 patients therefore underwent single ventricle palliation. The first additionally had partial anomalous pulmonary venous drainage, but good valvular function, and this patient underwent Norwood stage 1. The patient was subsequently diagnosed with Holt-Oram syndrome, had very poor pulmonary artery development, and died at 14 months of age. The second was small at 2.1 kilograms, but the left ventricle was borderline small and valvular function was good, and the patient was initially managed with pulmonary artery reconstruction and RVPA shunt in the hope of biventricular repair in the long term. Unfortunately, this patient was subsequently found to additionally have a long segment tracheal stenosis, and despite slide tracheoplasty and upsizing of the RVPA shunt, died at 15 months of age. The third patient was the one we had recently lost at age 5. He had complex anatomy with right atrial isomerism, tricuspid atresia, and hyperplastic pulmonary arteries, but the truncal and AV valve was unusually good. His initial procedures were PA reconstruction with right modified BTT shunt, followed by CP shunt at age 5 months, and both were well tolerated. Unfortunately, he required early Fontan completion for increasing hypoxia at 20 months of age, which failed and required takedown, resulting in permanent and marked renal impairment. After some time on the transplant waiting list, he was eventually removed from the waiting list and died at 5 years after a very prolonged hospital stay. The literature comprises a similarly small number of cases per institution, with some successful cases of biventricular conversion, but singular reports of successful Fontan completion. In keeping with this, we counseled the parents that the long-term outcome of single ventricle palliation was highly likely to be poor and results in poor quality of life. They nevertheless would not accept palliative care, and we finally agreed to proceed with single ventricle palliation. The patient underwent aortic arch repair, PA-plasty, and RVPA shunt, and a further concerning intraoperative finding was of an emphysematous left lung with widespread air in the interlobular septa. The patient nevertheless made a relatively straightforward recovery, extubated on day 3, and after some initial desaturation episodes on the ward that responded well to red cell transfusion, he was discharged after 21 days, demand bottle feeding. At 3-month follow-up, there was some echocardiographic evidence of increasing LPA stenosis, and cardiac catheter was undertaken with LPA balloon dilation and stent placement in the proximal shunt. At 5 months of age, a superior caval pulmonary shunt was created with further PA-plasty, and he again made a fairly straightforward recovery with discharge on day 8. At 11 months of age, he continues to thrive with saturations in the mid-80s and mild AV valve regurgitation, although we continue to keep a close eye on his pulmonary artery development. Fortunately, a repeat CT demonstrated no concerning features in the left lung, thought to be abnormal macroscopically at the time of surgery. Of course, we are still a long way from Fontan completion, not to mention good long-term Fontan success, and we therefore remain guarded about his outlook. The second patient I would like to present is one with anatomy I'm sure many of us have come to dread: right atrial isomerism with pulmonary atresia and obstructed total anomalous pulmonary venous return. The patient was born weighing 2.7 kilograms, had confirmed asplenia, cleft lip, and renal hyperplasia, but with normal renal function. Despite appropriately bleak counseling about the low likelihood of successful single ventricle palliation and a high risk of poor quality survival, the parents would not accept a palliative care approach. Some 4 or 5 years ago, one of our trainees had reviewed outcomes in patients with isomerism, and in patients with right atrial isomerism, the very worst outcomes were in those that required an arterial shunt and TAPVD repair at their first intervention, with, from this review, what appeared to be no long-term survivors of this procedure. We considered a transcatheter palliative approach also, but we're concerned that stenting of the collector may compromise the left pulmonary artery. On parental request, we therefore proceeded with TAPVC repair, PA-plasty, and right modified BT shunt on day 12 of life. In keeping with preoperative, pre- and post-pulmonary vascular abnormality, the patient had a very stormy course initially, requiring re-exploration and clipping of the shunt for hemodynamic instability, the medical management of SVT, and renal replacement therapy. After 7 days, she however turned a corner, allowing delayed sternal closure and extubation on day 10. She made remarkable progress on the ward with discharge on day 16 on a combination of NG and bottle feeding. I'm sure we all appreciate that this is again very much only the first skirmish of a long war, and that the literature shows that the first year remains a high risk period for patients with right atrial isomerism. Even after this period, there remains a steady rate of attrition, with most series demonstrating only 40 to 50% long-term survival, and few have been able to demonstrate an improvement in these stark numbers over time. We, however, had another look at our own data and found that some serious errors had been made with the previous review. There were actually 2 long-term survivors after TAPVC repair for obstruction and shunt as a first procedure, both being well more than 10 years post-Fontan. But the results remain far from good, with 38% survival at 1 year in this subgroup. The early deaths were due to sudden hemodynamic collapse in 3 and recurrent pulmonary vein stenosis in 1 patient. Arguably, 2 very early postoperative deaths due to intracerebral hemorrhage in the early 90s, and 2 from sepsis may be prevented in the current era, although immune problems in asplenia, of course, remain a challenge. As for our patient, she had an admission at 3 months of age with bronchiolitis, requiring a brief period of ventilation, and mild turbulence had developed in the pulmonary venous confluence. She had also been diagnosed with severe gastroesophageal reflux disease and malrotation. At 5 months of age, she underwent cardiac catheter with right pulmonary vein confluence balloon dilation and was accepted for bilateral CP shunts and pulmonary vein revision. The surgery was completed at 8 months of age, leaving the BT shunt patent to encourage pulmonary artery growth after redo PA-plasty. She had a difficult recovery with wound infection, microaspiration, and oxygen dependence. At 11 months of age, she underwent gastrostomy, fundoplication, and LAD procedure, with improvement in her respiratory symptoms. Unfortunately, at 2 years of age, she represented after a prolonged stay abroad with neurological deficits and was found to have developed a large cerebral abscess with mass effect. This was drained on 2 occasions with improvement in her neurological symptoms, but cardiac catheter also demonstrated occlusion of the left CP shunt. She suffered a marked respiratory deterioration shortly after the catheter and sadly died. Thankfully, these complex anatomies now present rarely with increased rates of antenatal detection. A much more common cause for debate and concern is abnormal AV valve function. The Australia-New Zealand registry demonstrates a rate of AV valve failure, that is repair or replacement, or the development of moderate or greater degree of regurgitation in around 10% of patients, and this is clearly associated with Fontan failure. Patients with a common AV valve are at a clear disadvantage, with around 50% AV valve failure at 20 years. The systemic tricuspid valve or two AV valves still perform less well in the long term than the isolated left AV valve in tricuspid atresia. In a large study from the Mayo Clinic Fontan database reported recently, a very similar rate of AV valve repair or replacement of 13% was demonstrated. In concordance with the Australia-New Zealand registry, AV valve intervention was associated with an increased risk of death or transplantation, but the important finding of this study was that if performed before Fontan completion, the risk of death or transplant was similar to the overall cohort. The risk was, however, increased if repair or replacement was undertaken at the time of the Fontan, and even more so if performed after the Fontan, with a hazard ratio of 3.83. An important caveat, however, was that AV valve repair failure occurred in 11%, and that this was significantly more common in patients undergoing repair before Fontan, that is in 54% versus 6% after Fontan. Additionally, replacement carried a 2.9 times higher risk of death or transplant as compared to repair. Importantly, as this report only studied patients that had actually reached Fontan, it only gives a partial view of the problem and the false impression that AV valve regurgitation is only a problem if it is not repaired by the time of Fontan. Single center studies have repeatedly shown that whether in patients with hypoplastic left heart syndrome or patients with various other functional single ventricle morphologies, the requirement for AV valve repair at the time of stage 1 palliation is associated with significantly poorer survival, as demonstrated here in red, as compared to repair at the time of stage 2 in blue or after Fontan in green. The same studies also repeatedly show that the worst outcomes in this category of patients are in those with impaired ventricular function, be it after repair with a good functional result in terms of regurgitation, or in patients with significant residual regurgitation after the repair. There is little evidence for one repair technique over another, and also little evidence that improved repair techniques have resulted in an improvement in outcomes. Anecdotally, we have found the PTFE bridge repair extremely valuable in common AV valve repair, and more recently have also had some success using this technique in systemic tricuspid valve anatomy. It will, however, be some time before we have followed up these small number of patients for long enough to judge whether this will translate into a durable improvement. The evidence that earlier AV valve repair translates into better outcomes is therefore debatable. It is clear that patients that have poor AV valve function from the outset represent a very high risk subgroup, and that those in whom AV valve regurgitation develops later but before Fontan completion and undergo successful repair seem to do relatively well after Fontan. In conclusion, the common theme in the scenarios I have presented remains: judge the individual patient and their associated anatomy and comorbidity, not the anatomical subgroup. We have been caught out by erroneous impressions gleaned from a quick look at our past experience. A review of patient outcomes should always be conducted carefully and with the intention of learning from past experience, not solely to identify subgroups for exclusion. The management of single ventricle patients with significant AV valve regurgitation remains a major challenge, and early intervention before deterioration in ventricular function is important. Patients needing AV valve repair at the first palliative stage, and particularly those with existing ventricular impairment, form a very high risk subgroup, and long-term outcomes are poor. Thank you for your attention.
presentation. We would be talking about this for a long time if we have enough time. But if I just start the discussion, I would want to know, in your conclusion, you said about early AV valve repairs. Have you started doing that at all?
Well, I think patients who need AV valve repair at the time of stage 1, we generally tell parents that the long-term outlook is poor. All the data that is out there suggests that these patients don't do well in the long term, especially if there's already impairment of function. Usually, when we get into AV valve repairs, patients who don't need it at stage 1 but are starting to develop problems in the first interstage or in the second interstage, and yes, then I think ideally, you need to have it sorted before they go Fontan. Risk for us still, I think, doing a repair or replacement at the time of Fontan is higher risk. So better to sort their valve out before they actually undergo the Fontan procedure. In
terms of the two cases you described, I felt the tone of the description that you feel that whatever you do to those patients, their outcomes are poor. Is that something correct feeling? Do you think?
Well, our team, the reason I brought these is because they're contentious. Our team feel, there are some who feel that we shouldn't be operating on these patients anymore. If you look back at our experience, it's over 30 years. Someone getting a cerebral abscess while they're abroad for a year, that is potentially preventable. And then, we have survivors. Could we do better now? That's the way I think we need to approach it. As long as the parents know that these are bad anatomies, I think in the end it comes down to discussion with the parents. And we try to both of these parents were counseled the one was counseled antenatally, very bleakly, and they wanted to proceed pretty much regardless, unless we can offer them an alternative. And you can see why. If you have even if it's a 20% chance of survival, it's hard to explain to parents the risks of poor outcome, right? This is the hardest thing to explain. You may get a survivor, but they may have a very poor quality of life. And what they understand is that if they don't try the surgery, the mortality will be 100%. So these are tough discussions, right? And usually they need to be had repeatedly to be able to, really counsel well. And like in that first patient, we didn't really have that time, because once we had the child intubated, things seemed to spiral, and we couldn't extubate the child again. So then there isn't that time. Only in retrospect do we know if the right decision was made, right?
Yes, yeah. One of the things you mentioned about antenatal counseling for these patients. Do you think that as a surgeons we have to take more aggressive part in the counseling for these patients? Because I get a lot of times this patient has got actually terrible anatomy, terrible AV valve regurgitation, and been told actually that the surgeon will fix it. It's just so. Would you think that we should take a stronger take at antenatal counseling, and how is the practice elsewhere?
I think if you see that situation where the parents have been counseled while the surgeons can fix it, then probably you do need to be involved more. I think our fetal cardiologists counsel quite bleakly. I worry sometimes that we for instance, we haven't seen a obstructed TABVC that needs a shunt TABVC repair and isomerism for several years now, and I suppose they're counseled in such a way that many parents choose not to proceed. I think from what I've seen, when surgeons counsel antenatally, generally we're even more optimistic than fetal cardiologists, right? I don't know. It depends on what your fetal cardiologists are like, I suppose, whether you think, certainly from what I've seen, and for instance, the first case I presented, antenatally, it really didn't look that bad. It looked like an unbalanced AVSD, but with a relatively small aorta and a good AV valve and a good truncal valve. So I would have counseled, I think, if I saw them antenatally, that, I think we can do single ventricle palliation, and there aren't major risk factors for a very poor outcome. But then when we saw, that it's truncus, and then our whole perspective shifts purely because of the previous common arterial trunk single ventricles that we've had. In the end of the day, it actually made the surgery simpler, right? We didn't even need to do a Damus, but we worried about those PAs, right? If they crossed origins and even, 2 PA plasties, we're still worried that they don't grow normally. And, that's the long-term goal, is to have well-developed pulmonary arteries. You set yourself up for a bad fontan if you can't get those pulmonary arteries to grow well. Right?
There are no questions on the chat, and I encourage people, participants, to put some questions. Any questions from Rafael and Mohammed?
No.
Yep. No, just a comment. I think that Phil, I think that was absolutely great that you share that experience, because it's and that's the beauty of today's meeting. I think that we is not here to show off. It's here just to show, like, how can we, work, make decisions together. And they are such a difficult decisions. And I absolutely applaud the fact that you go back and look, our experience 10, 20 years, have a quick review of what's going on, and just put all the decision together. And yet, once again, the surgical challenge or the technical challenge is not there anymore, meaning like we can do that operation. So it's not that it's a technical exercise, we can do it. It's all about is the right thing to do or not. That's the main decision. And because, can you do an OR with a small PA? Yes, you can do it. Can you do this? And we love to do that. That's what we enjoy. But this, as a human being, is this the right thing to do or not? And with the parents, it's a tricky one, because many parents come, if you give me 1% chance, please take it. And the reason probably is it's very, very difficult for a mom and dad to make a decision, just switch off my baby. I think that's a very, very difficult one. And probably you need to be involved palliative care, because they know how to talk to the parents and so on. But I think that it's great that you share all that, and I think that I learned a lot about this decision making from Birmingham and how to approach some of the cases, and even encouraged me more and more that when we were talking about months ago, let's try to do a national consensus group, because as the same way that we're doing it together today, tomorrow we might have a case and we just run a quick MDT amongst all of us and see what you think. And rapidly we can have with some ideas or support for a decision that we have taken. I think that we will encourage Mohammed and Phil to move that forward. But great presentation, Phil. Thank you.
There is an anonymous questioner. It says, for extreme hypoplast left heart, is it not only survival, but also what is these children and parents go through? Needs ECMO, trauma, the whole experience of having a child in such conditions, multiple operations, more than the 3 advertised, in and out of hospital for many years. Not sure if they are always aware.
Absolutely. I think that's what I tried to get across. And like Rafa said, technical challenges were not so great in these patients. It's not that we did amazing operations. It's just that the substrate is there and it remains there. And these are the hardest things to get across to parents, right? You can tell them about survival and percentages. That has nothing to do really with, the back and forth to hospital and repeated admissions. These are difficult questions. And, I applaud, I agree with you, Rafa. It helps to get second opinions, but ultimately it's you talking to the parents and trying to persuade them one way or another what your team thinks. And some parents, as you say, will not accept, and even palliative care. They won't even speak to them. They say, "I'm not interested to hear what they have to say. I want to try."
Yeah, we are. It's quite tricky. And probably it's exactly the same. I don't think it's anything different. But to answer the question from the forum is that I think that was 3 or 4 years ago. I remember this family came and it was 6 child, super lovely family. And I established a relation because the dad was from grandparents from South America. So we managed to speak a bit of Spanish. And I remember chatting with him and he lost his job. The kids who were teenagers were like a bit lost. And I did a study with, not myself, but I encouraged the psychologists to do a study of single ventricles, all the Fontanes, what actually happened with these families. And the impact in families and siblings is phenomenal, meaning in a bad way. So the amount of divorce, the amount of the other kids in the family being neglected, not because they want to, because the amount of care that a single ventricle kid need, even the good single ventricle, is tremendous. So it's just trying to put all that into context when we make decisions.
Thank you. For the sake of time, shall we go for your presentation, Mohammed?
Yes.
Thank you.
Thank you. Good afternoon. We're going to share with you a single ventricle case that we found decision-making really challenging. So Peter was born in 2001 with hypoplastic left heart syndrome. During neonatal period, he was palliated with first-stage Norwood, and at the age of 6 months, he had tricuspid valve repair and augmentation of supravalvular aortic stenosis. A couple of weeks after that, he had a tricuspid valve replacement with 17 millimeters endued, together with a glen and patching of his left pulmonary artery. And by the age of 2, he had an extracardiac 18 millimeter non-fenestrated TCPC. He's got other non-cardiac diagnoses, got celiac disease, delayed puberty, and he's claustrophobic, so we never managed to get an MRI. So all surgery was done in Germany, and we first met him in Newcastle back in 2006. And according to the clinic letter, everything was good. However, his parents were counseled that this tricuspid valve will get small at one point in time and will need replacement. All went well till 2015, when he started to have some intermittent face swelling and abdominal distension. In 2016, he had mild ascites on ultrasound, and on echo, the gradient across his tricuspid prosthesis was 7 millimeter mercury. He had a catheter at that point, which showed a Fontan pressure of 20 and a gradient across the tricuspid prosthesis of 2 millimeter mercury. In 2018, the ascites became moderate, and he showed reduction of his exercise tolerance, and a CT at that point has shown the liver to be on the small side, nodular in shape. That was his echocardiography at that point in time. And that was his Doppler showing a transvalvular gradient, a peak of 33 and a mean of 18. At that point, he had another catheter which showed the same Fontan pressure of 21 and a transprosthesis gradient of 6 millimeter mercury. At the same time, they stented his LPA. That's his CT, and as you can see, his liver is on the small side, a little bit nodular, but more maybe abdominal distension and full of ascites. And you get a CT chest here showing a significant calcification of the batch that was previously used for augmentation of his DKS, and the relation of the batch, the calcified batch, to the left pulmonary artery stent. So what would be the options for this gentleman? Would we believe the echo data and say that he needs a tricuspid valve replacement, and that would probably reduce his Fontan pressure and improve his symptoms? Or shall we believe the catheter data and say that the pressure gradient across this prosthesis is not significant, and actually it's a Fontan failure and we should go for a transplant? It was a big discussion at the time between different members of the team, and at the end we were not sure what is the best option to offer to this young man, and we counseled the parents as regard both options. Peter himself was keen not to have a transplant, and the family decided to go for tricuspid valve replacement. That was done at the end of February 2019, where he had the 70 millimeter prosthesis was replaced with a 27 Magna-East tissue valve, and because of the calcified patch, we could not cross-clamp the aorta, and we've done it on a fibrillating heart. At the same time, we added a 5 millimeter fenestration, and as it is a redo replacement or tricuspid valve, you cannot really trust the conduction system, and although he came off in sinus rhythm, we decided to put an epicardial pacing system. The operation itself was difficult, 115 minutes of fibrillation to replace the valve, dealing with all the collateral and a huge amount of backflow, and the bypass time was over 3.5 hours. However, he's done well. He discharged from PICU 10 days afterwards, but he had a longer stay in hospital because of electrolyte imbalance and arrhythmia. He went into atrial flutter, fibrillation, and in and out of complete heart block. But at the end, he went home. That's his echo on discharge, showing a mean valvular gradient of 5 and maximum of 15. So follow-up a month later, and these are the description of his own cardiologist. He's looking frankly better and is full of energy, denying any tiredness or breathlessness, chest pain or palpitation. Comes July, and again from the clinic letter, he looked significantly improved from both preoperative and his clinical status discharge, with significant improvement to his ascites. His face is not swollen. And at that point in time, we said, great, we've done the right thing. Come September, he feels well. However, the ascites comes back. May, a year afterward, feeling more tired over the past few months. Comes June, ultrasound shows a massive ascites is back. So apparently everything came back to what it was. That's the echo at that point in time. And that gradient of 5 is now 10. Went for CAS, no improvement in fontan pressure, still the same, and transprothesis gradient of 4. So currently, he's got still massive ascites and getting ascitic fluid tapping every 4 weeks. We've decided to list him, and he's been on the transplant list since July last year. However, he is sensitized, and his HLA tissue typing excludes 50% of donor. So reflecting on his story and his clinical journey, we got a few questions. I would leave it for you. First is the timing. When would we replace a prosthetic valve? Shall we believe in the echo transvalvular gradient, the caster, or shall we go for the indexed effective orifice area or geometric area or weight size ratio? And if we go for a valve replacement, what prosthesis shall we choose? A mechanical or a tissue valve? And finally, the ultimate question is those patients with single ventricle circulation and residual region. Should we go for routine surgery, or would a transplant be the best option for them? I guess these are a few questions that we can discuss in the open discussion and see how everyone's thinking of it. Thank you.
Thank you, Mohammed, for sharing this experience. Can I start just with asking, at what age did he get the first valve? I didn't catch that.
6 months.
6 months old. I see. And what type of valve did they put in?
Put in a 17 millimeter St. Jude metal valve.
I see. when you took the valve out, how did it look like, the valve itself, and how did it look?
The valve had a pannus underneath, so it was even smaller than the geometric area for a 17 millimeters angiogram.
I see. I'm looking at the questions. The question: was the clinic in an outpatient setting? Was the drain removed in the outpatient clinic, or was the patient taken to the ward area for this? I don't know whether this question is for us, actually.
I don't think it's for us. There's no drain in this patient.
No, I think it's probably to another room. So I think, Mohammed, this patient is unique. I've got to say, one of my comments would be about the choice of the valve for replacement. I do quite a few Epsteins, and when I am faced with patients, they're older patients, they are late 50s or later, I would always replace it with a porcine valve, and I think you chose the Magna Ease. I don't know if that profile is good enough, or maybe a mechanical valve. I'm not sure about the choice.
So one of the reasons that we decided to use a tissue valve is that we had a couple of experience with metal valves in Fontaine with blockage of the valve. Actually, and quite recent, close to his time, and that's why we decided to put in a tissue valve. But frankly, honestly speaking, a metal valve might have been a better choice. But would it have made a difference? I don't think so.
I think the patient has got to a stage, probably in your center, you would have probably done a transplant on him if you would have seen this outcome coming, don't you?
Yes, you would have seen this. Now he is on the transplant list, and that's why I came with a question to this panel to discuss. So one of the questions, we had a discrepancy between the echo gradient across the valve and the transcaster calculated gradient, because he cannot cross the metal valve, so it was a calculated gradient. So if any of you were in my place, what would you believe? A 17 millimeter in a 17-year-old child, would you believe a gradient of 6, or would you believe a gradient of 18?
No, I think it's patient prosthesis is much like a 17 millimeter in an adult is too small, especially in an AV valve, whatever position, tricuspid or mitral valve. So probably you're right. There is so much noise when you do an echo that trying to measure a gradient across that with echo probably will be very difficult. And I think that your option of what would be my decision making to change this is, okay, 17, either tricuspid or mitral valve, regardless if it's single ventricle or not, in an adult-sized patient, probably that need to be changed for that. I mean, the timing is a tricky one, but probably maybe some time ago. But why after you improving the hemodynamics, the physiology came back? Maybe it was because it's like an end-stage Fontaine, I suppose, with a little bit of contribution of the AV valve, but maybe it's just coincidentally an end-stage Fontaine.
Yeah.
I don't know what you think.
Yeah. Phil, what do you think?
Well, I don't think anyone has more experience than Newcastle with trying to answer this difficult question. The traditional surgery and patients referred for transplantation, I think Newcastle has published, and the series that you have, I think it demonstrates how difficult these decisions is, and you only again know in retrospect whether you made the right decision. I absolutely agree. I think I would have gone for that. The valve cannot be big enough, even if the echo is a bit misleading. That just cannot be a big enough valve in that patient. And then, yeah, your question is absolutely, should we have just listed for transplant? You can't, because he could stay on the waiting list and deteriorate and get to a point where he's untransplantable so easily. And at the same time, you kind of, what was his PRA before it? And you're sort of weighing this difficult question. This is not going to be an easy surgery ever. And you're going to end up transfusing quite a lot of products and maybe make his PRA worse. It's so hard. And everyone, in the literature, it makes it sound like it's a no-brainer. Oh, yeah, just list for transplant. But the reality is they got a long wait ahead of them. They get, they don't get the organ because it's going to be such a hard, difficult transplant. I wish I had the answer, but if you don't have it, no one has it, right?
And Mohammed, you had a target, and clearly this is a small valve. I mean, it's you cannot argue with whatever test you're going to do. This valve is too small, and probably if I came across it, I'd probably do the same.
Yeah. So that's get me to the last question here is when patient with single ventricle presenting with a residual lesion, and in this case it was the small prosthetic valve, but we get some patients who are in a Fontan doing really well, but for example, a double-ended left ventricle, or where you get a some residual LVOT obstruction. In a very good Fontan, would you go ahead and you do the surgery on them, or you say we'll wait and later we'll just list them? So that's the big question in all the Fontan residual lesion.
I think that you have so the root of a Fontan is which is a palliative operation, as we know. So it's not a curative. Is you are going to carry on living and then dying, or you're going to carry on living and having problems, and some of them will be solvable. And we are always will be forced, especially in good Fontan, and if you have a residual lesion like subaortic membrane obstruction or whatever is, or LVOT obstruction, it's probably worth to go and we don't go and trying to solve that. With the AV valve is the same issue, because if I put it in the other way, if I was sending that patient to Newcastle, I mean, you and Asif will tell me, well, why you didn't change the valve first? We are going to change the valve and see if that works. So that will be. So I think in that particular case that you presented, it was justified. If you have an absolutely endless amount of donors in which you can have the choice, the discussion will be very different. But because we don't have that off-the-shelf donors, that's why we need to every patient in a different way, and probably exhaust as much as we can the possibility that we can fix something and keep buying time. However, I think that you are demonstrating more and more in Newcastle that it's probably better to bring somebody for a transplant with a bad Fontan, but the rest of the body in good conditions, rather than bringing somebody with bad heart and the rest of the body in bad conditions. And that's the part that we outside Newcastle we need to learn to even at least to discuss early, and at least it's in your panoramic view that case might come in your way.
There is a question here. I don't know if any role for lymphangiographic studies.
Well, we don't have much of experience with that, and to my knowledge, it's maybe the Evelina. I don't know, Phil, if you do the lymphangiography study, but to me, it's Evelina that they do it, and not all patients.
Our experience is in its infancy. We're trying to develop some experience, but certainly not lymphatic intervention yet. We're trying to learn at least which are the ones, which have a clear abnormality of the lymphatic system, and then perhaps which are the ones where we could consider, kind of a Ruska kind of approach, an ominous vein turn down or something. But first you need to really get to grips with the anatomy, lymphatic anatomy. I think this patient, it's always we learn from doing the lymphangiography, but are you likely going to cure the problem? His CVP, before you reoperated and afterwards, his PA pressure was high, right? 21. So most likely his lymphatics are just not able to cope with, with the pressures in his venous system, most likely. That's my general feeling. But I think we're all learning about lymphangiography really still.
There is some work ongoing with MRI and for the lymphatic system, and our experience here with our interventionists trying to look at that in infants, but not older patients.
Yeah. One other thing I want to comment is that, with our generation inheriting all these fontans from 20 years ago, sometimes the decisions at the time for single ventricle, two ventricles were correct at the time, and maybe things have changed now. And one of the, in fontans in problems or even without problems, it's good to have a look again and say, can I rescue this into a biventricular or 1.5 ventricle, even if it's a fontan? Because you will be surprised, and occasionally those who are already en route for fontan or already in fontan, some of them, especially when the decisions were taken beforehand, like unbalanced ABSC, etc., some of them might be candidates for attempted biventricular rescue or even 1.5 ventricle. Because what we need to think, and I remember, probably Osama remember this, like, when we were our registrar and Kevin, who was our consultant, and said me, well, the only thing that we're doing is creating an epidemic of single ventricles of single ventricle failures in 20 years' time. So that's what's going to happen. And what are the right predictions? So what you have is a huge epidemic of patients, not a huge, a number of patients, which we cannot offer anything. So they are, but probably it's a natural history. So with that experience is like just to reduce the burden into Newcastle or GOS, etc., or the transplant unit, is to see always just to review, can this patient be rescued or not as a biventricular? And you might find, I don't know, one a year or twice a year. And certainly in older care, we review quite a few with Ram and Attilio, we've been, and the cardiology team. And some of them who's been en route towards fontan, change directions and attempt to either 1.5 or 2 ventricles. And I'm sure it's the same in Newcastle and Birmingham.
One of the historic patients, you're talking about those patients who's been done previous generations, so to speak. The patients with a single ventricle with TGA dependence, their systemic circulation depends on going through a VSD, and those patients initially were abandoned. If they come to me nowadays, it's just no way you're going to have to leave them dependent on a pathway which is is going to be a trouble in the future for a fontan, and it hasn't been dealt with before. We are quite aggressive in those patients nowadays. But even when we get patients who had obstruction, we take them back and we deal with it, because I think if you leave it, these patients, their life is limited anyway. If you make it better for them, that limited time, it would make a difference for them. So I agree. I think you've done the right thing of replacing the valve.
It didn't end up well for him. He still owns it.
Yeah. I think we ran out of time anyway. It was a very nice presentations from everyone. Thank you so much for sharing that. Any comments? Any other thing you wanted to mention?
No, thanks to everybody. I think that was a great session, Osama, and thank you for sharing the session. You did a great job.
Thank you so much. At some point, I lost the Wi-Fi. Sorry for that.
I would like to thank Rafa for organizing the whole thing. You did a great job.
No, I think that was all team effort of everybody's.
Yes.
But
thank you. I really enjoyed it.
Make that for future meetings, Rafael. This is really a good idea.
Yeah. And then the next time we'll do it with a pint a beer or something.
in the meeting room. Yeah.
Yeah. Have a great day, guys.
Thank you. See you.
Thank you. Bye.